Now, the next speaker is Dr. Abhijit Kunnor, who was our own student, now one of the important faculty. After going from here, went through a lot of time in Canada and has come back. So he is going to speak to us on viral monitoring, post-transplant monitoring of CMV and BK virus. Abhijit, please go ahead.
Thank you, Team MPUH, for giving me this opportunity and to be able to speak on this August platform. So my slides are just loading up, so please bear with me for a second. Yeah. Sir, can you see my slides? Can you hear me well?
Yes, I can see your slide and I can hear you well. Go ahead.
Okay, so today I'm going to talk on the role of viral surveillance after renal transplant.
Hello. Hello.
So it's imperative to recognize infections early after renal transplantation. Immunosuppressed patients often present atypically and with far advanced stages of infection. Fever is a non-specific find, which can also be attributed to medications and acute rejection. Invasive testing and imaging is often required to make an accurate and timely diagnosis. So the journey of have immunosuppression is a fine balance between microbe, where inoculum, virulence, and latency plays a role, and the host defense mechanisms. Some basic principles of infection get affected in a renal transplant. So the inflammatory response is attenuated by immunosuppressants, which may abolish the typical signs and symptoms and decreased sensitivity of serological or radiological test. The effects of the established infection may be far devastating in an immunosuppressed individual as compared to a normal individual. And the treatment may also carry some toxicities like immunoglobulins and interferon therapy may promote rejections. Antivirals like acyclovir are nephrotoxic, and there may be synergistic nephrotoxicity when used with other molecules. So the major determinants of the risk of infection is the net state of immunosuppression that we are all aware of and the degree of epidemiological exposure. The net state of immunosuppression is in relation to the dose, duration, and temporal sequence of the drugs that are used. Also, the underlying immunodeficiency present earlier, like patients with lupus nephritis. Presence of catheters, tubes, central lines, which promote the possibility of infections. Presence of devitalized tissue and fluid collections, which our urology colleagues alluded to earlier, and the presence of neutropenia and lymphopenia. Underlying metabolic conditions like uremia, malnutrition, and diabetes promote and perpetuate this net state of immunosuppression. And viral infections themselves lead to immunomodulation, like the presence of cytomegalovirus, Epstein-Barr, and Hep B, C, HIV, which maybe promote rejections. So epidemiologically, the risk rate and type of infections vary over time from transplantation. Currently, there are no assays to measure the risk or susceptibility to infection. The risk of infection is an interplay between exposure history, intensity and quality of immunosuppression, and use of prophylactic medications. Classically, the infections may either arise from the donor, usually deceased donor, because live donors usually are screened. The recipient derived, where they have been harboring in the recipient body. Nosocomial, meaning the environment surrounding the donor and recipient. And finally, community acquired. So there is a changing timeline for the presence of these infections. Unfortunately, the COVID has come, both of them came together. But basically what I wanted to show was less than 1 month, usually the donor-derived infections like HSV, LCMV, rhabdoviruses, West Nile in some places, and HIV are some of the infections that we have to deal with. In the first 6 months, from 1 month to 6 months, usually the infections will be related to CMV, BKV, HCV, and other infections like HBV. And beyond 6 months, usually we are dealing with late CMV infections, hepatitis, HSV, and community-acquired infections. The viral infections typically also affect the renal allograft, and some of the common viruses which are renotropic and renopathogenic are BKV infections, CM infections, adenovirus infections, HSV, and Epstein-Barr virus infections, affecting various parts of the kidney and the systemic body. We ourselves in our hospital undertook a study by one of our very student, Avinash Rao, who is right now no longer with us, but is gone to Canada for further treatment, for further studies. And we wanted to find out whether active surveillance of viral infections does play a role in the outcome of renal transplant recipients. So as I alluded to earlier, viral complications have varied presentations, and the common viruses that we deal with are CMV and BK virus, and immunosuppressive regimens and routine prophylaxis alter the original pattern of occurrence. Prevention, as always, is the optimal approach. But as I alluded to earlier, that endogenous organisms like BKV and CMV, the allograft itself and the external environment play a role. The aim of this study was to analyze the incidence, prevalence, and complications of post-transplant viral infections using serological diagnostics. The material and method, it was a prospective, non-randomized, longitudinal observational study of 1 year, which was conducted in live donor renal transplant recipients from May 2017 to April 2018. And it involved serological analysis of blood samples at various intervals, 3-monthly intervals, and after any unexplained rise in serum creatinine, and after treatment for acute rejections. The usual immunosuppressive regimens that Dr. Gang and Dr. Hegde and others alluded to in our center usually consists of induction agents like ATG, basiliximab, in ABO-incompatible where we use plasmapheresis rituximab, and in some individuals who are well matched, we don't use any induction. The maintenance therapy usually consists of tacrolimus, mTOR inhibitors, mycophenolate mofetil, azathioprine, and steroids. And tacro blood levels were measured at each visit, and EGFR was calculated using CKD-EP formulae. The virological diagnostics for the BK virus was viral DNA copies of more than 10,000 were denoted significant infection. And urine BK DNA load of more than 10⁻⁷ copies per ml was considered threshold levels for presumptive disease. CMV viral load quantification by DNA PCR was a viremia if the CMV DNA was more than 1,000 copies per ml, and considered disease if CMV DNA was more than 2,000 copies per ml. Epstein-Barr virus serology was assessed pre-transplant. Patients were classified based on their peak viral load values during the follow-up into 3 specific groups. If viral loads were over detection level for both CMV, BKV, or EBV, if there were more than 2,000 copies were classified as elevated viremia for BKV, CMV, and Epstein-Barr virus, and more than 10,000 copies were high-level viremia for BKV, CMV, and Epstein-Barr virus. Hep C virus quantification using RNA RT-PCR levels were done, and any detectable amount of viremia was taken as evidence of infection. Hepatitis B seropositivity for hepatitis B surface antigen using ELISA technique was done pre-transplant at 12 months post-transplant. That means at the end of the study. Hepatitis B virus DNA levels were done using RT-PCRs, and immunoglobulin M anti-HBV core antigen and HBV E antigens were done to classify them into acute or chronic infections. And occult HBV was determined using positive anti-HBC and negative antibodies to anti-HBs antibodies. Patients were slotted into high risk depending on the donor EPV positivity as compared to the recipient EBV seronegativity. In renal transplant recipients after every 3 months, and then after any anti-rejection treatment was used. HIV studies were done using ELISA prior and 1 year post-transplant, and HPV was done in women prior to transplant, where we screen all patients for female patients for Pap-Nicolo and HPV PCR if any cellular atypia was noted, and 1 year post-transplant in these specific individuals. So 105 patients who underwent renal transplants between this study period were enrolled, and 2 patients were censured because of who died unfortunately because of post-operative complications, and 7 patients actually opted out of this study. And the study set actually consisted of 96 patients who were followed up for 1 year post-renal transplantation. The basic demographics, mean age of the recipients was around 36 years of age, and mean age of donors was 46. Male to female, as Gangsar had pointed out, a large proportion of the recipients were male, and a large proportion of donors were females. And total number of transplants were 96, of which ABO compatible formed a large proportion, 87. Mean vintage dialysis was around 4 months prior to the transplant, and the total ischemia time was not too broad, around 60-70 minutes for these transplants. Induction agents, as I alluded to earlier, ATG was used in 64 of these individuals, basiliximab in 16, desensitization protocols for ABO incompatible in 9, no inductions in 7. Valgan cyclover was used in most of the patients who received ATG and the ABO incompatible, so 73 patients. Second transplant was present in 4 of these individuals. Of interest, seropositive status for D plus R plus was for all the patients for CMV and EBV. The reason for chronic kidney disease in this study population, a large proportion was undetermined. Around 16% of patients were chronic glomerulonephritis, and a host of other patients formed around 2 to 5%. Prevalence of pre-transplant viral infection in the study population usually consisted of hepatitis C virus, which was treated for these patients in most of our subsets, around 7%, 2% were Hep B positive, 2% CMV, surprisingly, and BKV 1%, and 87% of the patients did not have any infections. Incidence of viral infections at various intervals post-transplants were noted and can be seen here. There's a peak of CMV infections which were noted in close to around 20 patients, and BKV was noted in around 4 patients at 6 months post-transplant. The kinetics of reactivation of CMV infection post-transplant, one can see that very few patients actually had more than 2,000 copies, meaning that they were having a disease. Many of them had transient viremia that occurred at around 6 months, and detectable levels were seen in a proportion of patients where they peaked soon 1 month and 6 months after a transplant. And the prevalence of viral infection at the end of study period, around 6 patients had CMV, and 1 patient was detected to have BKV. So large proportion of patients actually did not have any viral infections during and at the end of this study period. Kinetics of new serum BKV DNA detection post-renal transplant. Again, similar to CMV, one could see that majority of the patients did not have any BKV infection, whereas 6 months down the line, a proportion of patients which are less than 10% actually had detectable copies, but none of them copies which were was pathological. So if we actually went to consider the number of copies prior to transplant and detectable limits, one can see that very few patients actually were having significant amount of copies prior to transplant and cross the linearity range enough to consider them to be having the disease. Between the patients who developed CMV infections and patients who did not develop CMV infections, there was no serious male-female preponderance. As one can see, even amongst the ATG group, where we expected patients to have more CMV infections, a large proportion actually remained CMV non-infected. In the bacilimiximab group also, proportion of patients developed CMV infections, although did not reach a level of significance. The number of rejections remained similar in both these groups, and graft loss also did not reach a level of significance between these two groups. Amongst the people who received CMV prophylaxis to versus no prophylaxis for CMV, all patients who received ATG received CMV prophylaxis, and also ABO incompatible transplant patients received CMV prophylaxis. Only 2 patients developed CMV syndrome in patients who did not receive CMV prophylaxis. And graft loss at 1 year was not really very significant between these two groups. Comparison between BKV infected and non-infected patients. Most of the patients remained non-infected. Amongst the BKV infected patients, graft loss was noted in 1 patient, whereas in the non-infected patients, now nobody lost a graft. But one can see that rejections were more in the BKV non-infected patients. So etiological structure of post-renal transplant viral infections during this study, majority actually thankfully did not suffer from any viral infections. A large proportion, 30% of patients actually had CMV infections. A smaller proportion of patients had BKV, and extremely rare patients having parvovirus and herpes zoster. What about the GFR levels or the graft function? So patients who had CMV infections, actually the graft functions were significantly affected at the end of 1 year. So as compared to BKV, where the graft functions were nearly similar between infected and non-infected recipients. In this study, we noted that the limitations was a short follow-up of 1 year, and the effect of other bacterial and parasitic infections on the incidence and prevalence of these viral infections remained unaccounted. The influence of nephrotoxic medications and surgical interventions was a confounding factor which couldn't be noted. Graft outcome was based on EGFR calculations rather than histology. And the monitoring of BK virus infection was not done in accordance with the usual guidelines in view of the financial constraints that are present with the transplant population. From this study, we could conclude that Hep C was the predominant pre-transplant viral infection. CMV infections had high incidence and prevalence amongst all viral infections post-transplant. The incidence of CMV and BKV was highest at 6 months post-transplant. CMV incidence was significantly higher in patients who had graft rejections, and EGFRs were affected for patients who had CMV disease. Higher mean tacrolimus levels corresponded to increased CMV infection rates. And all patients who had BKV viremia also had viruria. So thank you for giving me this opportunity to share this experience I had with viral surveillance in post-transplant patients.
Thank you very much, Abhijit, for the excellent presentation as always.